Kia ora everyone. Welcome to this Goodfellow webinar this evening on incidental liver and pancreatic lesions, the triage, diagnosis and referral process. This webinar is kindly supported by Allevia Hospitals, and we have two highly experienced specialists presenting with us tonight. Firstly, we have Adam Bartlett, a general and laparoscopic surgeon specialising in the comprehensive management of conditions affecting the liver, gallbladder, bile ducts, pancreas, stomach and spleen. And following, we have Michael Chu, who's a general and laparoscopic surgeon, also specialising in liver, pancreas, biliary surgery, and renal transplant surgery. Welcome, Adam and Michael. And I'm going to hand over. I think Adam's our first presenter today. So, Adam, I'll hand over to you and let you share your screen.
Good evening. So, look, Michael and I both work as general surgeons, but have a subspecialty interest in management of liver and pancreatic conditions. And what we're going to talk about tonight is essentially the incidental lesions which are found, because patients are having so much more imaging, and just about every scan we do, there comes back with some finding, and is that significant or not? And if you're not careful, you can get yourself on this circle of more and more tests, more and more investigations, and not really coming back with any answer. So we'll hopefully be able to explain what these lesions are, which ones need to be investigated, and which ones can be ignored. So firstly, I'll talk about the incidental liver lesions, and I'll hand over to Michael, who's going to then talk about the incidental pancreatic lesions. So look, the first case is probably seen by a lot of us, relates to a 35-year-old fit and well female, has had one episode of right upper quadrant pain, no other symptoms whatsoever, no family history, has been on the oral contraceptive pill in the past, and examination revealed nothing of note, nor did the blood tests. So what's the next test which most of us will do? Well, it's a ultrasound scan. And look, the ultrasound scan, as can be seen here, shows a hyperechoic. That means increased density, that white lesion sitting within the liver. It's solitary, it's well demarcated, and it's said to be a heterogeneous mass. The report will say something like, this is most likely, but then they go on to say further imaging is recommended. The question is, well, what do you do? Do you ignore this? Because as I said, they're so common. Do you repeat the ultrasound scan in 6 months to see if it's changed? Refer for a liver biopsy? Request imaging by cross-section, either CT or MR. Granted, MR is difficult to get from the primary sector, or you refer to a surgeon. Well, hopefully, we've got sufficient access that you can request further imaging, which would be the standard. And in most places, the first imaging one would do would be a CT scan to hopefully give us the answer. And here can be seen the cross-sectional image of the liver, which shows in the center of the liver a hyper-enhancing lesion. Is the cursor seen? I hope so. Which is entirely in keeping with hepatic adenoma, which I'll talk a bit about later. Used to be a lot more common than they are today, but we still do see them. So look, to introduce the concept of incidental liver lesions, we need to appreciate that we commonly see them, as I outlined. They're said to be present in around 6% of CT scans. I think they're more common than that. The approach in this topic applies to liver lesions that are found incidentally. That is not patients which present with symptoms. Okay, that's different. If patients present with symptoms, they have a different workup. These are just incidental findings. The overwhelming majority of these lesions or masses, which we find, are entirely benign. They are not malignant, they're not tumors, they're not cancers. They are benign, but they cause a lot of anxiety. The risk of the lesion being malignant increases with age, not surprisingly, and in the setting of the patient having previously known to have a malignancy, especially those which have a propensity to metastasize to the liver, such as bowel cancer. So how do I think about liver lesions? The first thing I do whenever I see a patient, with an incidental liver lesion is they say, well, is it solid or is it cystic? If it's a solid liver lesion, okay, it's either benign or malignant. Most of them are benign. At the outset, you need to try and think, as I said at the beginning, incidental liver lesions, by far the majority, are going to be benign. And, it's rare for them to be malignant. The first thing you need to, however, think about is that, well, does the patient actually, though, have a increased risk of developing a malignant or a tumor within the liver? And that group of patients is essentially those with chronic liver disease or cirrhosis. In patients with chronic liver disease, they get a cycle of where they get injury, repair, and can accumulate genetic aberrations in their liver parenchyma, which leads to carcinogenesis. And that's why patients with cirrhosis or chronic hepatitis B end up with developing primary liver cancer. So in an incidental liver lesion in somebody who's cirrhotic, one does need to exclude hepatocellular carcinoma. How do you exclude that? Well, the tests are, first of all, to do a routine blood test looking at liver enzyme profile and the tumor marker alpha fetoprotein, which is said to be positive in around 80% of patients which have hepatocellular carcinoma. On the basis of the finding on ultrasound, you would then go on to do contrast imaging. As I mentioned before, CT would be what I would go to first, or you can go straight to MRI. And the sequence of the pictures on to the right here, the frames, show what you'd expect with a hepatocellular carcinoma, whereby what you see is non-contrast in A. You administer contrast, you see it into the arteries and the aorta, it starts to enhance. By the venous phase, it washes out and it stays washed out. And that would be characteristic of a primary liver tumor. So the next thing to ask is, well, does the patient have a prior history of other possible malignancies? As I mentioned before, there's certain malignancies which have a propensity to metastasize to the liver. The most common, which we would see, is colorectal cancer, which does spread predominantly to the liver because of its venous drainage. But other cancers from all around the body can present within the liver, although less rarely. And for them to reach the liver, they've often traversed systemically before they metastasize to the liver. So what is the approach if somebody does have other possible or has had a history of a malignancy? Well, the first thing to do is, well, check that tumor markers. If it's a tumor that secretes a tumor marker, see what the liver enzyme profile is. And then again, you need to do some form of contrast enhanced imaging, which would routinely be CT. Nowadays, we've stepped into doing a lot more functional imaging, which is we refer to as FDG PET, which is a type of functional imaging which looks at uptake of a tracer within the liver. And in certain cancers, FDG is taken up in a focal area, and it will make the diagnosis or confirm the diagnosis of cancer. Again, it's not something which is going to be available from the primary care, but it's something that we do use in the hospital type setting in order to help confirm a malignancy and or the stage, the extent of the cancer. So, where are we going? So, going back to the first diagram, the solid lesion, is it malignant? The first thing, as I said, to say, does the person have chronic liver disease or cirrhosis, or is there a history of malignancy? That helps you exclude the malignancy. Then the vast majority of them are benign. So what are the benign liver lesions? The three which you need to consider are hepatic hemangioma, focal nodular hyperplasia, or more commonly known as FNH, and hepatocellular adenoma, or more commonly just called adenoma. I'll work our way through these three different lesions. So what are hepatic hemangioma? They are a benign liver lesion, which is just dilated or a cluster of blood vessels, lined by normal endothelial cells and are fed by an hepatic artery. They're almost an aberration of normal development within the liver. Thus, they are said to have an incidence of 7%. And again, I'd challenge the papers which sort of quote this number, because I think we're seeing more, or they're more commonly seen. And probably the reason for this is the fact that our imaging has got better. They seem to be more common in females than males, and the majority of them are less than 3 centimeters in size. Because the innervation of the liver is principally onto the capsule, any lesion within the liver does not cause pain. So for a hepatic hemangioma to cause pain or become what we say symptomatic, it's got to involve the capsule of the liver, and it causes capsule to stretch. But it's incredibly rare for hepatic hemangioma to cause pain. So for the vast majority of patients which have a diagnosis of an incidental liver lesion, which is said on ultrasound to be consistent with a hepatic hemangioma, then one just needs to reassure them and no other further imaging or investigations is required. Most patients are going to end up having blood tests done at that stage. Do you need to do contrast science imaging? Not always. It is going to, most ultrasounds nowadays would be able to give you the diagnosis. If they can't give you the diagnosis, then by administering contrast, either by CT, MR, or more recently, we now have contrast enhanced ultrasound machines, whereby we inject little micro bubbles into the circulation, and then ultrasound, you can actually then mimic the circulation and confirm the diagnosis. But it's only just recently become available. So is the ultrasound diagnostic of hepatic hemangioma? If it's got typical features, it's small, that is less than 3 centimeters, and it's a female patient, nothing else is needed. You do not need to do anything more. And hopefully most radiology centers now are abiding by this and being quite adamant in their diagnosis, and are not saying thereafter in the next sentence, contrast enhanced CT or other form of imaging is required. That's not necessarily, as long as it's classic on ultrasound, it's small, and it has the characteristic features. So what about focal nodular hyperplasia, or FNH? Again, this is a benign liver lesion that's composed of hepatocytes, which is surrounded by a classic little stellate scar in the center. It's said to occur in around 2% of the population, and is more commonly seen in females. It does not require surveillance. The exception is, though, if you've got a large area of focal nodular hyperplasia that is greater than 5 centimeters, one has to be careful that they have differentiated it from hepatocellular carcinoma. But in the vast majority, they are very small and they can be easily characterized. The final benign liver lesion is an hepatocellular adenoma. As I said earlier, we used to see a lot more of these than we do now. The reason being is that their growth is driven in most people by the presence of exogenous estrogens or anabolic type steroids. Prior to the reduction of the estrogen content in the oral contraceptive tablet, we used to see a lot of patients, young females, go on to develop hepatocellular adenoma. We still do see it in our patients, but certainly not nearly to the same level as what we used to. It is a benign liver lesion, but there are some that do require further characterization, because they are at risk of malignant transformation or bleeding once they get beyond 5 centimeters. All adenomas do require follow-up and or possibly treatment. So although it's a benign condition, it does require specialist evaluation to determine whether it does require treatment or further evaluation. So the workup of these patients, in a similar fashion to every other incidental liver lesion, does require liver enzymes to be measured, but also checking AFP to exclude hepatocellular carcinoma. And the patient does require contrast enhanced imaging to confirm it definitely. As can be seen here on the pictures to the side, is actually a patient with an adenoma, arterial enhancing, and here another patient where it's bled and they've got a hemoperitoneum, which, as I said to you earlier, is a risk of these conditions. So the treatment in vast majority of these patients is ongoing surveillance, avoidance of exogenous estrogen. Nowadays, particularly in females, we are biopsying them more commonly. Why? Because we can subtype them and determine whether they need treatment or not. Any hepatic adenoma in a male, however, does require surgical resection. So what else could a liver lesion be? As I said at the outset, liver lesions incidentally found can either be solid or cystic. And so the other group, which we haven't covered off, are cystic liver lesions. They are more common than solid liver lesions and almost always are benign. Very rarely are cystic incidental liver lesions malignant. The most common would be what we refer to as a simple hepatic cyst. What does that mean? Well, that means a benign hepatic cyst. Very common, often seen on ultrasound, which is the diagnostic test for them. It's better than even CT. It can be associated with conditions such as polycystic liver disease or autosomal dominant polycystic kidney disease, whereby they express cysts within their liver. It could be an abscess. I doubt it. We used to see a lot more. We are seeing a resurgence of this because we're no longer treating dogs for echinococcus routinely, and really biliary hematoma, but they're all very rare conditions. So what is the diagnostic approach? Well, most, as I said, are diagnosed on ultrasound. Ultrasound is very, very good at characterizing cystic structures because they contain fluid, which enables us to get good windows. Most are would you describe as a solitary benign cyst. The complex cyst sometimes require further imaging. What does it mean by complex? Complex means that it's got either septations within it, like you see within an orange, or it's got mural nodularity to the side of it, or a combination of both. These become difficult to characterize because the more complex the cyst is, the more likely it may actually be associated with underlying condition that does require surveillance and or treatment. Ultrasound scan is not always going to be the only test, and sometimes you need to do more evaluation of these patients. A lot of patients, however, though, which we get referred, which have complex cysts, where we see septations, are actually cysts side by side, which are pushing on each other. So it's not true septation; it's just cysts in close proximity to one another. So what do you do with a patient who's had incidental simple cysts? So that is a cyst without any septations, without any mural nodularity. First question is it larger than 4 centimeters or not? If it's not, no other imaging is required. If it is, does the patient have symptoms that could be attributed to the cyst? Well, what would the symptoms be? Almost always will be a pressure, because the cyst, as it gets bigger, will cause pressure on the liver capsule, and patients will say they have a fullness under the rib cage. If they don't have any symptoms, then just leave it alone. I don't tend to mind how big the cyst is if it's not causing any symptoms. If, however, the patient would be a candidate for surgery and they're having pain or symptoms that could be attributed to the cyst, then one could be referred for consideration of drainage of the cyst. We used to just drain the cysts by putting a needle into them. In doing that, however, they universally just recur very quickly. So what you need to do is fenestrate, that is, take the wall of the cyst off, which is a very straightforward, simple operation. Opens out the cyst and it stops it from causing pressure, and the patient's symptoms go away. So what to do with the unnamed liver lesion, and what are these? Well, they're becoming less common. They're the liver lesions which we don't know what they are. We can't give them a name. Historically, it used to be more common, but as we've got better with our imaging using MR and other contrast agents, we're able to categorize liver lesions much better than we could in the past. The options really are to either do surveillance, keep watching it, because if it doesn't change over interval time, it's unlikely to be of concern. It's more likely to be benign, or biopsy it, histological evaluation. It's really going to come down to a further discussion with regards to the perceived risk to the patient that this may be something more sinister. And as I said earlier, if the patient has a past history of any malignancy, then their risk would be deemed higher. What the level of the patient's comfort is in watching it versus getting histology, and also is it able to be accessed? And I'm not sure if many people have had a liver biopsy or seen them. They're not exactly procedure which patients stand forward to willingly, because it is quite invasive to have that procedure done. But we, and for that reason, we don't tend to do many biopsies nowadays, because our imaging tends to characterize most of them, and we tend to try and avoid it if we can, and just do surveillance imaging if that is possible. So look, just to summarize through about the incidental liver lesions, they're commonly seen on all imaging studies. The vast majority of these are benign, and that's where one should start the conversation with the patient, because most patients, as soon as you tell them they've got a lesion or a spot or a mass within their liver, they immediately think that's a tumor. The first management step in trying to establish is it something of concern or not is to evaluate their malignant risk and obtain further imaging. The malignant risk really comes down to, do they have underlying liver disease or not, or do they have a history of cancer or not? That will evaluate the malignant risk. Then you always determine, is it cystic or solid? Cystic lesions are almost always benign, and only a minority of solid lesions are malignant. Biopsy of liver lesions, as I alluded to, is really required nowadays, and we can normally get an answer or obtain adequate reassurance through further imaging. And an uncharacterized liver lesion, as I said, is increasingly rare and do require surveillance, but often not forever. Often what I tend to do is do an interval at, say, 6 months, double interval to 12 months, and then 2 years. And then if it hasn't changed over that period, which is roughly 3 years, I tend to reassure patients that it's almost certainly a benign lesion, because it hasn't changed over that length of period, and we can probably leave it alone, although we can't give it a name. I'll hand over to Michael, and he can continue to talk about the incidental pancreatic lesion. Thanks, Mark.
Thanks, Adam. So I'm going to talk about incidental pancreatic lesion, and start with a case, as Adam did. It's a 50-year-old fit and well male, presented with 3 days of vague rapid colon discomfort, reduced appetite, and presented with dark urine and pale stools. No family history of note, and when you examine them, he's clinically jaundiced and nothing else. You did some simple blood tests, showed a bilirubin of 90, mildly deranged liver function tests are slightly up at 1.4, and the tumor markers that we normally do for the pancreas is normal. So there are options that we can do. Obviously, it's different in primary care or in the hospital. So we can repeat the bloods in 24, 40 hours, make sure everything's okay. Ultrasound, CT, and the following test. I like to start normally with just the common things. Common things happen commonly. And as you get the ultrasound scanned, these are the 4 panels. And they do mention sludge in the gallbladder, which is this gravel here. And then the 13mm dilated CBD, which is a common bile duct, and the dilated pancreatic duct at 4mm. So the pancreatic duct is not normally seen on ultrasound scan. And when they do see it, you have to have concerns, and that's what we call a double duct sign, which means the pancreatic duct and the bile duct is both dilated. And now going back to the algorithm, what would you do next? Ideally, you would probably get an MRCP or MRI pancreas, and as Adam alluded to, it's hard to get it in primary care. So sometimes we get a CT pancreas first, but most of the time, the patient's probably going to end up getting both CT and MRI scans. So in this MRI scan, there's a mass at the head of the pancreas, and with the dilated common bile duct and pancreatic duct, and it's going to be likely a pancreatic malignancy. And if you do find this scan, what do we do? In an ideal world, is actually going to urgent surgery. So the recommendation around the world is actually if you can get a whipples within 1 or 2 weeks, there'll be an ideal world, but we don't actually live in one. So I'm going to go through that as a background case, and that's because the most important thing to roll out. So as Adam alluded to, pancreas incidentaloma or pancreatic incidental lesions are very common now because we do so many scans, and the scans are so much better than they were in the past. So they have a wide range of lesions from small cysts to large invasive tumors. And obviously we can focus a lot on the invasive cancers, but we do have to realize that a lot of these lesions are benign. And the risk of the lesion being malignant increases with age and also the subtype. And I'll go through different types of pancreatic lesions that we would see. Pancreas lesions, again, are solid or cystic. And if they are cystic, they're either mucinous or non-mucinous. And I will break them down further. If they are mucinous, these are the more common one that we see, mucinous cystic neoplasm, and the one that we always worry about and see, intraductal papillary mucinous neoplasm or IPMN. In the non-mucinous group, it's just a serocystic neoplasm that we commonly see. And if we do have a solid lesion, it is more concerning, and that's where we start worrying about cancers or pancreas adenocarcinoma, or neuroendocrine tumor, or even a solid pseudopapillary neoplasm, which is actually a pre-malignant lesion. So the risk factors that we help in decision making about seeing a patient, we always think about excluding pancreas cancer because that's the worst diagnosis that we can give to a patient. And as Adam alluded to, same with the liver, is that if you have chronic inflammation of the pancreas, so chronic pancreatitis, a family history, smoking and diabetes and obesity, it's actually increase your risk of pancreatic cancer. And in America, Ashkenazi Jew and also African Americans have a higher risk of pancreatic cancer as well. So I'm going to focus on the 3 different subtypes of mucinous cystic lesions, non-mucinous, and the solid lesions. And in the pancreatic cystic lesions, we see so much of them. They're just pancreas fluid-filled structures within the pancreas. And as I mentioned, divided into mucinous and non-mucinous. And if you see this, what we call the worrisome features or things that we worry about on a scan is the size of it, bigger than 3 centimeter. And if it's affecting the main pancreatic duct, which is bigger than 5 millimeter, or a mirror nodule, which is a solid component of the cyst. And if you start worrying about the pancreas distal to the lesion, then we start thinking about cancers or other sinister lesions. And I mentioned CA19-9, but as everyone knows, that CA19-9 is not secreted in all patients. So the patients have to have a certain antibody to be able to secrete CA19-9. So a normal CA19-9 can be falsely reassuring, and obviously rapid growth of a lesion. And going to the solid lesions, they are the main reasons that we do pancreas surgery because they have a high malignant potential, and the differential diagnosis can be very difficult, especially in small lesions. And that's why we need to careful workup these lesions. So the common blood tests that we organize would be a liver function test, CA19-9, and again, not everyone has these tumor markers. And CT or MRI pancreas is the scan of choice, because most of the time the ultrasound scan can't really see the pancreas very well because of bowel gas and the structures in front of the pancreas itself. So the contrast enhanced imaging is our primary modality. CT scan is very good for looking at the relationship to the blood vessels, and most of the time we can get the diagnosis from a CT. But if they don't get the diagnosis, then we do an MRI scan just because of further characterization of the pancreas itself. Pancreatic biopsies are very, very rarely performed and only done in certain cases. So if a patient has a cancer that's proven, we think it's cancer that we need to give chemotherapy to try to shrink the cancer before surgery, then we do need to have a biopsy just to give the oncologist a bit more information about what type of chemotherapy or therapy to give prior to surgery. Or if you're considering palliative treatment or options, then we do need a biopsy as well. And obviously, if we don't know what it is, and sometimes we do a pancreatic biopsy. Some people argue about laparoscopy. Similarly, it's very rarely performed, and it's only performed if you're worried about peritoneal disease, because the peritoneal disease is very hard to see on imaging. Even a PET CT will not pick up small disease, but that's very, very rarely done. So I'll talk about two endoscopic maneuvers that we do for pancreas surgeries. One is an EUS, also endoscopic ultrasound, where they have an ultrasound probe at the end of the endoscope. And we do it normally if we're not sure about what the mass is, or if we need tissue biopsy prior to chemotherapy. These last 2 points of lymph nodes and vascular involvement are rarely used. So it's more commonly used in America and in Europe, but for us, we do not use this as much. We do it for biopsy reasons and also to get histology. And a lot of people ask me about what about ERCP? There are only 4 real indications for ERCP in pancreas cancer. One is cholangitic, or cholangitis, where the pancreas lesion have obstructed the common bile duct, patients becoming septic, and that is a life-threatening thing, and the patient will need an ERCP. Or if the patient is jaundiced but not cholangitic, and they've given chemotherapy, we will need to drain the biliary tree because the oncologist will not give chemotherapy if the patient is jaundiced. Or these last 2 is kind of symptomatic. One is severe itch from the bilirubin, or they're malabsorbing because of the lack of bile salt in the system. The reason we not do ERCP as much is because of the risk of pancreatitis and causing the risk or adverse event of an ERCP. So I'm going to go through all the lesions individually. The mucinous cystic neoplasm, or MCN, is a lesion in the pancreas with a distinct ovarian stroma. So it's almost exclusively in females. So if you see in a male, that's very, very rare. But luckily, it is very infrequent. And they have potential for malignant transformation in these type of lesions. And going to another case is a case of mine, a 39-year-old female represented with pain after cholecystectomy. An MRI scan showed 2 tiny cysts at the tail of the pancreas, and they call it likely side branch IPMN. They are about 3 to 5 millimeter in size. Now, I did have a question about IPMN, and here you go. So there are lesions of variable invasiveness, typically in the 5th to 7th decade of the patients. There are no difference between male and female. I used to say more common in male, but now we know it's actually no difference. It's probably because we're doing more scans and we've got more data to reveal that they're not actually any different. They are very commonly found on imaging and always raise the question, what do we do with these? So the malignancy rate depends on the morphology type, whether it's involving the main pancreatic duct. So it's divided into side branch or main duct IPMN. So a side branch IPMN is where a branch of the main duct is involved with IPMN, and they are mostly benign. But they should be monitored for a certain time period. But if you have an IPMN of the main duct itself, it is pre-malignant and has a malignant potential. So it should be treated if the patient is fit for major pancreas surgery. So it's a pancreas surgery. There are no minor pancreas surgery. So all pancreas surgery are major, similar with liver surgery. So IPMN does cause a lot of anxiety, including for the surgeons, and the surveillance are very intensive. If you look at the guidelines around the world, they actually recommend scanning every 6 months and then endoscopically EUS for every 12 months as well. In our system, in our country, I don't think that's feasible, and also cause a lot of anxiety for patients and surgeons. I think we should be very pragmatic and do scans probably every 12 to 24 months. And going to the next cystic lesion, which is non-mucinous, which is a serous cystic neoplasm. It's a benign lesion, generally in the older age of 60s and above, and it can slowly grow to become very large, and they can be left alone unless they're symptomatic, and if they're causing size for compression of other organs around it. And the next solid lesion is SPN. It's very rare again, and they're in mostly young females. Unfortunately, most of these lesions are more predominant in females, and these are thought to be pre-malignant or with a good prognosis, and have to be cautious because some of these lesions histologically actually turn out to be neuroendocrine tumor. So solid pseudopapillary neoplasm and neuroendocrine tumor can be very confusing or on a scan as well. The next solid lesion that we will talk about is pancreatic neuroendocrine tumor. It is the second leading cause of solid lesions in the pancreas. Incidental lesions are characterized as being less than 2 centimeter and with a grade 1 differentiation. So that's what they call a truly pancreatic neuroendocrine tumor incidentally. and they can be functioning or non-functioning. And to be honest, if you have a less than 2 centimeter lesion, non-functioning and low Ki67, which is a marker of cellular activity, so it's not very active, these can actually be monitored, and can just repeat scanning and can reassure the patient. And this is the one that we obviously all worry about. These are the most common cause of solid pancreas incidentaloma. It is a very poor prognosis despite advancement in chemotherapy and surgery. It's very hard to pick up early. So in Japan, what they've done is 40% of asymptomatic cancer of pancreas are found to be in stage 3 or 4. And their 5-year survival is 30%, which is quite remarkable. About 15, 20 years ago, the 5-year survival of pancreatic cancer is about 5%. It hasn't that is quite remarkable compared to what we have in the Western world. And the type of surgery depends on the location of the lesion. I'm just going to put it all into a table. So I'm sorry to use female names, because what we see is these lesions are mostly seen in female patients. So the solid pseudopapillary are called the daughter lesions, the mucinous are the mother lesions, and the serocystic is the grandmother lesions. These two are low-grade malignant or pre-malignant, and they should be resected with good prognosis, and these can be left alone. But if the patient wants to have a discussion, then refer to a specialist. And I put in pseudocysts, which, as most of you would have found, is that it's a collection of pancreatic fluid. Behavior-wise, it is benign in terms of whether it's cancer or not. But it's the patient demographics and the patient's outlook are not, because of the reason why they tend to be in the hospital for quite a long time if you've got severe pancreatitis. And they should be reviewed by a specialist. So these two are what we talked about as side branch and main ducts. So the side branches are, this is the main pancreatic duct, and these are just branches off the main pancreas duct. And these are benign and should be monitored. But if you have a main pancreatic duct IPMN, if they are fit for surgery, you should offer resection. All these surveillance protocol and recommendations are based on the fitness of patients' comorbidities and whether they're fit for major surgery. If you've got someone that is unfit, got severe heart failure or severe lung disease, they're never fit for surgery, we will probably caution them about surveillance, because if we won't be offering any surgery for them. So just a quick flow diagram about pancreatic lesions. If you have a pancreatic lesion, you check symptoms with a jaundice, weight loss, or pain. Start with a CT pancreas, and we can consider endoscopic ultrasound and biopsy. And if you're found to have any of these lesions, then we should have a tailored multidisciplinary care with surgery, oncology. And for us as pancreas surgeons, the key principles is always confirm resectability prior to biopsy. Biopsy is not without its risk, and obviously bleeding or pancreatitis. And if it's a typical of cancer and resectable, we do avoid biopsy. We all discuss it at our MDT meetings. Just to show all of you guys what a Whipple's procedure is. So you remove part of the stomach, bile duct, gallbladder, head of the pancreas, and duodenum before we rejoin them. So we do try not to put patients through this procedure unless absolutely necessary. And just to show a couple of live patients about what a Whipple's procedure looks like, this is the cut end of the pancreas with a stent in the pancreatic duct, and that's the common hepatic artery, and that's the portal vein coming down. That's before we join the patients up again. And similarly, this is just what it looks like after we've resected the specimen. Just a summary, pancreas lesions are very commonly seen. Again, we're doing so many more scans, and they are much better at picking up these smaller lesions. And it's basically, we base all our diagnosis mostly on imaging and evaluate the malignant risk of patients' risk factors. And the majority of solid lesions are malignant, so we do worry about the solid lesions, but the cystic pancreas lesions are mostly benign, and obviously depending on what subtype they have. And the biopsy of pancreas lesions are generally performed, if we have to, by endoscopic ultrasound, just because of the route and the closer you can get to the lesion. And again, depends on the patient fitness and comorbidities. That's where we offer surveillance or surgery. Cool. Thank you.
Thanks so much, Michael and Adam. I might get you to pop back on too, Adam, so we can answer some questions. There are a couple of things I've taken home from that. One was around, it seems that pancreatic lesions might be the worst lesions to have compared to liver lesions. They seem malignant and requiring more surgery as a intervention. Michael, you spoke to some of the age groups for the pancreatic lesions, but with the liver lesions, you had a case that was a young-ish female, a 35-year-old female. Is that the common age group that you tend to see some of your liver lesions? Oh, and obviously there might be different ages depending on what the diagnosis is, but can you speak a little bit to the timing of age?
Yeah. So almost all of the benign liver lesions, which we seen in a young age because they're developmental. Most of them are. So hepatic hemangioma, simple benign cysts, FNH, adenomas do tend to be in the younger age group. Absolutely right. And if you have a liver lesion, solid liver lesion in an older person, as I outlined, it's a red flag straight up, isn't it? The older you get and you're found to have a solid liver lesion, that's something to think about. Is that actually malignant? So our imaging is amazing nowadays, how we can store it. God, as a house surgeon, we used to all be on that plastic, and you'd lose them, you couldn't find them again. Now, because they're all stored forever, we can always go back to imaging. It's amazing. We go back to like 1990 now. Digital imaging is stored, and so we can compare. So now when people do a scan and they say incidental liver lesion C, you go back and compare. If it's been there 20 years, benign straight away. And so comparators are enormously powerful. But the same in all organs, if you can got a comparative. Solid organs are great for imaging. Hollow organs are hopeless. And so pancreas and liver are ideally suited for imaging and trying to find things. But yeah, almost all the benign liver lesions come at a young age, correct?
I had one other one around the tumor marker testing that you spoke to, Michael, around the pancreatic lesions. And I guess you initially presented the case as that would be one of the first blood tests, or within the first workup of a case. Is that what you would normally expect? Because I'm not sure in primary care that's not something that we would necessarily step into straight away, and certainly some of the biases to not do it.
Yes.
Keen to hear your opinion on that.
So I'm obviously from a Chinese background. Coming from Asia, everyone gets. I'm sure you primary health cares have seen Chinese patients or Asian patients going back to Asia, done a health check. Everyone gets a panel of tumor markers as a screening tool, and they come back, says CA19-9 is slightly elevated, and you go, oh my god. Oh, so as in the first time, if they've got no pancreas lesions, I would not do your tumor markers off the bat. They're not screening tools. And as I alluded to, not everyone secretes CA19-9. So normal CA19-9 with a pancreas lesion doesn't mean it's not pancreatic cancer. It's good if it's up for us you can check markers and surveillance, but if it's not up, it doesn't mean anything to us. And I have to advise my family back home, said, do not go do these tumor markers, because they screen and they go, as they send me a text, what does this mean? And they go, oh, I'll shake my head.
Yeah. So the pre-test probability becomes incredibly important in what you're ordering. So with our patients, for the type of presentation that you had there, you may wait. So you may do the ultrasound scan as a starter ahead, and then do the tumor markers depending on the results.
Yeah. And also I have to agree with that. If you're jaundiced, your CA19-9 goes up anyway.
Yeah.
So you have to wait for it, and then you go, oh, is it really up because of tumor, or is it because of becoming jaundiced? And you go, oh yeah.
Yes, and I think with the liver lesions, our health pathways recommendations are often around exactly the same thing. Be judicious, really hold back unless there's a significant pre-test probability or advice to do so. And certainly that wouldn't be an expectation for referral to have those results all through. No.
No, not at all. Most of them tumor markers are most helpful in monitoring treatment. That's where they're most useful nowadays, I think. And as you say, they're so misleading in so many people. But if you have somebody on treatment and they were a secretor of it, it's very helpful and reassuring for the patient going forward to monitor it long term.
Fantastic. And I think, Michael, you've answered a question that came through around metabolic disease being a risk factor. Do you mind just expanding on it a little for the audience?
Yes. So we mention metabolic disease, I think, as Adam alluded to in the liver, is that if you've got inflammation or injury and you keep coming back to repair, similar with the pancreas, is that if you have injury repair, then you're obviously predisposed to cancers or pre-malignant changes. And for us, and obviously metabolic disease is basically you try to stress your pancreas, trying to secrete more insulin. And I think that's kind of long-term, that's what they have. Obesity is part of the risk factor for pancreas cancer. But we don't understand that as well in terms of pancreas cancer genetics. I think a lot of it's genetics. We probably have a lot of family history of genetics that we don't know about that cause pancreas cancer. But just like a predisposition to injury to the pancreas. Yeah.
Yeah, brilliant. I think Adam's just typed another answer about, yeah, if a patient has chronic pancreatitis, then they should have annual imaging and bloods. So again, it's just that advice around it. Adam, you're answering something around LFTs and the liver function tests as a blood test. I guess it would be really great to hear from either one of you around how we should be using them to their best effect.
They're so misleading. They're actually misnamed. They're not actually liver function tests. I could give a whole talk on that, but I won't bore you with it. Essentially, they give us an indication of where the injury or what's going on in the liver. So cholestatic or hepatic, but they don't actually tell us about the function. But the main rule, why do you do them if you see an incidental liver lesion? Because if you have abnormal liver enzymes and a liver lesion, the likelihood that it's a more sinister liver lesion goes up if they're abnormal. So if somebody has an entirely normal liver enzyme profile and a liver lesion, you can be more reassured that it's probably not going to be something sinister. And the other thing is that if the liver enzyme profile comes back as being in a certain pattern, it may help explain why you got the liver lesion, if that makes sense, i.e. biliary obstruction or some other injury going on. So they are helpful, but essentially they're more reassuring if they're entirely normal. But that's not to be said. You can get a completely normal liver enzyme profile and still have a metastasis in your liver. We've seen that. So it's not always a given.
I guess, Michael, is there anything that you want to talk to? I know you've answered quite a few just while we were chatting then. Is there anything that you want to talk to in some of the topics that have come up in those questions? The audience can see your answers, which is really helpful. But is there anything you'd like to expand on?
One of the questions was about pancreatic biopsy, about whether we do it laparoscopically or endoscopically. I think it's all surgeon dependent, and I'm speaking about it with Adam, but if possible, I think endoscopic biopsy would be the best way to go. One, it's a lot easier and it's a direct route to it, because to get laparoscopy, to get into the pancreas, you have to move things away, and then it's a risk of surgery and general anesthetic. So for my preference would be endoscopic biopsy if possible, and try not to put a patient through laparoscopy or general anesthetic if possible.
Brilliant. And likewise, Adam, is there anything, I know you've again also gone through and answered quite a few questions. Is there anything that you would like to pick up on or expand on in those questions that have come through?
I think the thing which most people need to be reassured by is that most of these lesions are benign and they don't need to be referred in. They don't, and radiologists are getting better at being more definitive, which is very, very, very helpful. And it's easy also to even just put a referral through either through the portal system into the public system, whatever, and say our advice. And you say, this has come forward advice, that it's pretty quick for one of us to type 2 sentences to say, ignore, leave, move on. And that often is enough. But the problem arises in these patients which get on the, wanting scans done and wanting surveillance done. It builds up so much anxiety. And it's really just trying to realize that it's normal. Hey, I've got 4 spots in my liver, in fact, I know about. And, so there's part of a normal development of a liver.
Yeah, I think that's really good advice, because I know you touched on it in your presentation around the anxiety, and that's exactly what it does. Right. And I think the practical steps of how we can manage people have been fantastic. Thanks from both of you around both those 2 topics. And I think then how we get them to you and where we talk to the next steps for patients is really useful to give them some clarity around the next steps regardless of the outcome. So look, thank you very much both. I think again everyone's sending in their thanks. And so on behalf of everyone, thanks so much for the presentations. They were really clear and articulate and covered it perfectly from our point of view in a very practical manner. So very much appreciated. Thank you both.
You're welcome.
Very much.
Thank you for having us.
Cheers.